given you the news and he's weighed out the options and you're wrestling with, gosh, what decision do we make? What do we do? What do we not do? Said, if your mother were here in the room with us and she just heard everything that the doctor said to us, what do you think she would tell us to do? What would mom tell us to do? You know, if she were here with us and she just heard the doctor explain everything, or she could look at herself in the bed right now, what decision would she make? And that invites her to come into the room, and it cuts through, like, what do I want to do? Or what does my sister want done? Or what does another family member want done? What do I think should be done? It's like, what would mom tell us to do if she could speak for herself right now? And often that cuts through a lot of the emotional fog. Another way of asking a similar question could be something like, hey, if your mom were in the room with us right now and she heard the decision that we just made, would she say thank you? Would she thank us for that decision? Or would she say thank you for the decision we're thinking about making? And often that can invite them into, like, gosh, how would mom really feel about this? Or how would my wife or my husband or whoever it is? So I find that sometimes just these really helpful clarifying questions can alleviate anxiety and guilt, because it's hard. Just acknowledging that, I think, makes it hard. And I think in my work with families, one of the things that I just encourage them to do is I say, you just make the best decision in love that you can make for your family member, this person that you love. Make the best decision in love in light of everything you know about what they would want. And at the end of the day, that's the best you can do. That's just the best any of us can do. And that's enough. And that's okay. And so as we kind of go into these decisions, you know, last week we talked about, hey, what are the things we can do to have these conversations or to make these plans and to lift off some of that burden where we can, but just recognize that it's going to be hard. And we can do what we can. And so have compassion on yourself and on everyone around you. And I've seen families struggle, and I've seen families do beautifully through these. And these can be really profoundly meaningful times for family members as they pull together to make these kinds of decisions. So that's all I just wanted to say, a word of context and encouragement to you. Just acknowledge that this is hard. And I'm going to turn it over to Maggie. And Maggie, I just want to say I'm totally looking forward to your prayer. So thank you for opening us up and setting the context for today.
Thanks, Jeff. My offering tonight actually comes from a poet, Liesl Muller, and one called Monet Refuses the Operation. Doctor, you say there are no halos around the street lamps in Paris, and what I see is an aberration caused by old age, an affliction. I tell you, it has taken me all my life to arrive at the vision of gas lamps as angels, to soften and blur, and finally banish the edges you regret I don't see, to learn that the line I called the horizon does not exist, and sky and water, so long apart, are the same state of being. 54 years before I could see Rouen Cathedral is built of parallel shafts of sun. And now you want to restore my youthful errors, fixed notions of top and bottom, the illusion of three-dimensional space, wisteria separate from the bridge it covers. What can I say to convince you? The Houses of Parliament dissolve night after night to become the fluid dream of the Thames. I will not return to a universe of objects that don't know each other, as if islands were not the lost children of one great continent. The world is flux, and light becomes what it touches, becomes water, lilies on water, above and below water, becomes lilac and mauve and yellow and white and cerulean lamps. Small fists passing sunlight so quickly to one another that it would take long stringing hair inside my brush to catch it. To paint the speed of light Our weighted shapes, these verticals, burn to mix with air and change our bones, skin, clothes to gases. Doctor, if only you could see how heaven pulls earth into its arms and how infinitely the heart expands to claim this world. Blue vapor without end.
Well, Maggie, so many just amazing images of the impermanence of life, and also that there's not much difference between where we are and where we're going. If you would put the poet's name in the chat, I would really appreciate that, because I'd love to go back and reread that.
Okay.
Especially that the gaslights as angels, that's the seeing those halos around that beautiful golden light is such a powerful image. So my little part tonight is about going back to that list of concerns and just reflecting on some of the ideas and reactions that we had last week. I realized maybe it wasn't a good idea to put leaving loved ones first, because for some people in my group that, you know, we couldn't even get past that one, the idea of leaving those you love behind, whether they're children or parents or grandchildren or friends. So if you have avoided that document this week, may I suggest that you go back and pick one that's easier for you, and especially one that may be approachable is the unfinished business, the idea of getting something done before we pass out of this world. And for me, you know, I've been talking about death for years, and I know for many of you, this is probably very, very new to you. I know Jeff and Shannon and Judy and Maggie and all the wonderful facilitators we have here. We're used to thinking about these things and how this existence segues into whatever you believe comes after. But for some of us, that's a very sudden and definite transition. There's like, we're here and then we're gone. And so if you can think of unfinished business, and especially in terms of what legacy you might want to leave, and there's so many ideas for legacies, from recipe books to letters for special occasions, birthdays, weddings, graduations, that kind of thing. To address what Jeff was talking about, one thing you can do is write a "you're not guilty" letter, right? You know, just when you get to the point where you can write honestly about your feelings about dying and afterlife, share those with those you love and say, "to be opened upon my death." What would you say to them at that point if you were conscious? Some of us will be, some of us won't be. But, you know, in the end, we don't have much control over that time of our life. And I know some people are saying, well, why should we even do any planning then? If, you know, it's like having a birth plan, and how many of you actually followed your birth plan to the letter, right? I ended up with a C-section the first time, very unplanned. But it gave me some sense of peace around the fact that I was going to be going through this situation of giving birth. And so for me, thinking about it ahead of time, getting my advance directive in place, and working on what legacy, what is my unfinished business, that has provided me with a lot of peace around the fact that impermanence is real, that we will not be here forever. And want to acknowledge that all of us are at a different place, right? Like I was saying, some of us have talked about this for years, decades. Some of us may just be coming to it for the first time or very recently. And the importance of having these conversations with those who will be around you cannot be underestimated. We'll be talking about advance directives tonight, and they're not always followed, but if your family members are all knowing what you want, chances are much higher that you'll get what you want, whether it's at home or in a hospital setting. And that involves conversations. And I will add some fun ways to start these conversations. There's this game called the Death Deck, and there are cards you can play, you know, just answer questions. Some of them are just answer the question. I'll just read out one or two. And so bucket list. If you knew you'd die in a week and money was no object, what 3 bucket list items would you check off your list? So it's a gentle way to take on the topic of death. There are also a book called Let's Talk About Death Over Dinner, and you can have a dinner party where death is the subject for those of you who are courageous that way. So there are lots of resources out there. We'll be talking about some more in the 3rd and 4th sessions about how to have these conversations. So it's a practice thing, right? We don't talk about death much in this society, and this is a place and time to start. And yeah, I think we're ready to move into our next section then. Thank you.
Okay, thank you. Hey, good evening, everybody. We're going to be looking at some slides together. I think that we learn well listening and also seeing. And so there are going to be a number of slides, but don't get caught up in the busyness of them. I'll talk through every little part of it. We have time to come back and ask questions about them also. The arc of our conversation is about making decisions before it becomes a crisis. And you remember last week we heard from Jeff that there's one side of the paradigm where you bring yourself, and the other side of the paradigm where the doctor and medical team bring themselves, and you meet each other in the middle to try to come up with your plan. And we're going to just touch again on that. Kimmy, if you'll do the first slide.
Sure. Just one moment.
So here we're talking about shared decision making. And shared, so sharing with who? You're sharing with yourself and your family, and also the medical team. And remember that Jeff talked about, what do you want in your life or your illness condition? What would you hate? And what could you tolerate even if you didn't like it? For example, I wouldn't really like it if I were in a wheelchair. I might come to tolerate that, but I might not say I hate it, but I might tolerate it. I'd like to give it a shot if I had to. So there are things that I would prefer, things that I would absolutely hate, and things that I could tolerate. It's worth identifying what those are based on the questions that you received last week when Jeff was talking about you. Coming to these kind of conclusions. This information is captured in the advanced directives of the living will. This, at best, is the blueprint of your wishes. It's not the full detailed prospectus of what you want your life to unfold, because you cannot know all of the little details. But to the best of your ability, you pull up the important things, the values, your hopes and expectations, fears and worries. Then next is that the healthcare team, their obligation now is to speak to you about what might be possible, including potential treatments for whatever is ailing you, the risks and benefits of those treatments, the prognosis based on the science, and then the chance of you really meeting your personal goals. So if you really could not tolerate the fact that you would be in a wheelchair for the rest of your life, and your medical team is saying you never will walk again, that is really important information for you as you wrestle with coming to the conclusion of what's next. Kimmy? All the way down, coming up with your goals and plan of care. So it's really clear that the more planning that you do in advance, the better you can absorb new information, because you're not adding crisis on top of crisis on top of crisis. Next slide. And when you can plan, you have heard from both of our previous speakers and from previous speakers even last week that planning is the same thing as doing love. It enhances your personal peace and the peace of your family. These questions are, what is life for me? What would I hate? And what quality or condition of life would be tolerable, even if I don't like it? For most folks, it's pretty simple. Most people would say, I want to live the best life possible. I want to fix whatever disease I can. I want to prevent and relieve suffering. And I don't want to do high burden, low value treatments. I think we could pretty much agree that most of those go without further explanation. We are creatures who do not like uncertainty. And so to the degree that we can know and plan by speaking with ourselves and being clear with others, we can leave behind fears which keep us constricted and in dis-ease. Tonight, we're going to be looking at the planning documents that you can put in a portfolio, wrestling and coming up with ways of speaking and ways of being clear moving forward. The first one is the healthcare proxy. They say you should do this when you're 18 years of age. The person who's the decision maker, again, Kim? And again, Kim, thank you. The decision maker can be your parent, a spouse, your friend. It doesn't need to be your spouse. And I want you to hear that you have perfect freedom to let it be somebody who really will speak on your behalf, because it is brutal sometimes, these decisions. And these decisions are tough, and they require somebody who knows what you want in detail, what matters to you, and also that person should have the fortitude to support you with your expressed wishes when you can't speak for yourself. And that's when the healthcare proxy becomes important, when you cannot speak for yourself. The hashtag on the blue line shows that some time goes by, our life goes on. Every decade or so, you should again ask yourself, is this healthcare proxy person the same person who is the best decision maker for me, the one who knows me the best, the one who understands my physical wishes and my physical limitations, if any? Every time you get married or divorced, get a new job, move to a new community, you could ask yourself again the same question: is this the best decision maker for me in my context at this age? And it will change. Like Jeff says, it's scary, but none of this is written in stone. Your life unfolds in a process as these planning documents evolve as you do. Eventually you get to the stage where you have advanced directives. Now, who should have an advanced directive? Anyone who's human, I would say. Anyone who is beloved. Why? Because it is one of the most loving things to do on behalf of yourself and your family who love you. For sure, you should have them if you are playing around with having a serious illness, and we all will come to this at some point. We are all of us only temporarily abled. At some point, we will become ill, and we will seek the care of a specialist and curative physicians and treatments. And in the mix of this, we may also get palliative care, which I will speak about a little bit later in the talk tonight. Next on the planning documents is the POLST form. This is the physician orders for life-sustaining treatment. This is a doctor's order. It is not the same thing as an advanced directive. It does add to the clarity of your wishes, and it is usually done when somebody is very, very seriously ill, or we can use the word gravely ill, or if they are just ready. I have an example for you about just being ready. I know someone who's been so chronically ill for probably 20 years, off and on, in and out of hospitals, in and out of ICUs, nearly died so many times. And this person that I know is completely ready to go. She's happy with being ready. She doesn't want to have another ICU experience. She doesn't want to have any life prolongation in any form. She would not ever want to be on a machine. She's really ready in her heart and soul, even if at this moment she's living at home independent and is not gravely ill. But she has decided she's not willing to go through the work and burden of the intensive care experience and what it would mean to her. So a rather unique situation, but not unheard of, especially as we have had lots of experience with illness. moving forward. Next slide. Amanda, I think this is where you take over talking to us about advanced directives.
Thanks, Shannon. Thank you. And I'm going to see if I can figure out screen share here. And I'd like to start with our healthcare power of attorney. And I would like to try and clear up some of the lingo because there's a lot of different words that mean the same thing for these documents. And in Washington, your healthcare power of attorney and your directive to physicians, they can be in one document or they can be separate documents. So let me see if I can do this. So I'm going to walk us through a sample here so we can see one. And I'd like to start with the healthcare power of attorney. People also call it your power of attorney for medical decision making. The person is referred to as a proxy, an attorney in fact, an agent. It all means the same thing. It's a person who will make a decision about healthcare if you're not able to. And that would include consent to treatment, medical records, being discharged, going into a healthcare facility. And Shannon covered a lot of this. Who do you choose? It's the person who knows your wishes best. And talk to them. A lot of people choose their agent just because they know they're close, but they haven't actually talked about this. So having these forms and not talking to the person in detail about your wishes, it can be confusing for that person. So the talk, I like the death deck, the cards idea. That sounds fantastic. I'd like to get those. So having an alternate person for your agent is a really good idea. If your first choice is not available or just not able to make those decisions for whatever reason, having a backup or 2 or 3 is a great idea. That person, of course, has to be 18 years old and can't be your doctor unless your doctor is your immediate relative. Talking about these things is great. Writing them down is even better. And that end of life Washington, that is a fantastic resource, even if you don't use that specific document, just to talk about things and go through with just sorting out some of those details as you can and going through it with your proxy. There's simpler and shorter ones too, if some of those details just seem like too much. And I'm going to walk us through a short one. This is not the one I use in my office, but it's the Washington State Medical Association one, and hopefully you can see this. It's just 2 pages, and it just talks about, here's your agent, what they can do for you, what they can't do for you. And I like this one because it points out that they can generally make your decisions for you. And this is our state of Washington law right here, taken right from the statute that says what exactly they can do. And this form is really great because it's simple. You have one person you can designate, an alternate, and then a small blank area for if you want to add any personal notes there, things that are really important to you. This document is not effective at all unless it's witnessed by 2 people or notarized. Either one is sufficient, but this form has a place for both, and I highly recommend that. 2 witnesses and a notary. And I will just blow through without too much legal detail here, talking about your advanced medical directive, and then I'd be happy to take questions if we have time for that. So this is another form that gets a lot of different names too, and this can be combined with your healthcare power of attorney. We call it a directive to physicians, a living well, advanced directive, healthcare directive. They all mean the same thing. And it's what you want done if you're in a terminal condition. And that's the difference here. This is for you're in a terminal condition, it's a coma, no reasonable expectation for recovery. And it's basically artificial life support is the main statute that covers it here in Washington. You can certainly add more detail, specific things like Shannon was talking about. These can be as detailed as you want them to be. Others of them, and I have this sample here, is again, just a very short, there's not much detail in here, but in paragraph C here is you're in a terminal condition, permanently unconscious, and you do or do not want life-sustaining support. This is the simplest one I've ever seen. The one we use in my office is I do or do not want artificial nutrition and hydration, or I do not want it, but give me pain medication as appropriate as a third choice. And I'll tell you that probably 95% of my clients choose that route. Although sometimes even between spouses, they differ. So that's interesting because to me, it says that couple really needs to talk about their specific desires. Again, this form needs to be witnessed by 2 people or notarized, and it's great if you can do both. And Shannon talked about the POLST. I won't go into any more detail there. In Washington, your doctor, your medical facility, a lot of times will ask for one to keep on file for you, or if you're not asked, you can ask if it can be uploaded to your file. Your primary healthcare provider, or if you're admitted to a hospital, can do that. The one thing I recommend not doing is putting it in your safe deposit box along with your healthcare power of attorney. People they think it's very safe and they put it in there and they lock it up, but no one can get to it when it's needed. So put it in a file cabinet in a really obvious place. Give a copy of everything to your healthcare agent, to your proxy, so that they can have their own copy of it too. And in Washington, a copy is just as valid as the original. And I'm happy to take questions if anybody has any, either in chat or flash a hand if we have time for that.
We have up to 10 minutes, so don't be shy for questions.
So this is Greg Abel. I'm not totally clear on the distinction between the advance directive and the POLST. You do need both, and they are distinct documents. Is that correct?
That's a really good question. In the advanced directive, I recommend anybody 18 or over get your advanced directive, no matter how likely or unlikely it is that you might use your advanced directive. Some of our sort of world famous cases that got this going in the state of Washington here was a young woman who was on life support. Some of you might remember, but she was in her 20s and she was on life support for about 10 years before they were able to pull the artificial life support after a lot of court battle. Her parents finally agreed. So that's the advanced directive. The POLST, and I think Shannon could probably better address this than I could, is something that you get from your doctor typically, and it's whether you want any sort of life reviving measures taken. And that's typically people who are already in a terminal or elderly. My dad is 85 and he has a POLST, and in the state of Washington, it's a green card and he has it on his refrigerator. And if paramedics show up for any reason, he doesn't have a terminal condition necessarily. He's epileptic, but he has said he doesn't want to be revived. So no measures are what he wants. And so does that clear that up a little bit? Shannon could probably address the POLST even better.
So the POLST is really initiated by your doctor when you're in a condition where that's going to be a necessary thing, maybe fairly soon or within the immediate future, potentially.
Yeah, I think that's right, Greg. If you are seriously ill and it looks like your life may be limited, Or if you've decided Amanda's dad doesn't want resuscitation regardless. I mean, he's not seriously ill, but he doesn't want to go through the heroics because the work of that would be more burdensome than beneficial, which is quite likely in most of the cases when you get to be older and a little bit frail. The POLST is something you can ask for sure. It doesn't need to be, you don't need to wait for your doctor to initiate it. A lot of times doctors won't because it takes time and there's emotion and there's challenge about it. So I think that the doctor can initiate it, but I think that it's safer if you do, if you've got somebody who sort of fits the bill. And it can be a really wonderful piece of paper because it is something which is a mandate where the advance directive is not a mandate. It's just your wishes. No doctor or facility is obligated to follow your advance directive. Medicare is is required to ask you for your advance directive, but they are not obligated to do anything that it says on it, which really underscores the real importance of having somebody to be your own personal pit bull if things get difficult. The POLST is usually saved for, you really don't want to have CPR. You really don't want to be on a machine. You really don't want to have artificial nutrition through a tube. You really don't want to have burdensome treatment because in the weighing of it, there's more burden than benefit. And it's tricky. Maggie, can you show your green card? I saw you have it right there. Yeah, so it's screaming green so that it can be seen on your refrigerator. And people say to carry this with you, take a copy of it, put it in your wallet, put it in your glove box, definitely give it to your decision maker. Julie Shyrock said, make a copy of the front and back and put it in your phone, scan it and have it available because in the time of challenge when you're the decision maker, you're not there and you've got your sick one in the ICU or in the emergency department in a surprise kind of way, you can send that right through your phone to the people who need to see that. And so that's really liberating. Yeah.
I would add one thing as well, like Greg, when I was in the hospital and I would talk to somebody and it was very clear to me that they had reached the point that Shannon was describing, like, if I have a heart attack, just let me go be with God, you know? Like I would ask, have you ever heard of a POLST? Has your doctor ever talked with you about a POLST document? Usually the answer is no, because most people don't know about it. And I say, well, you're at the place where you should really do a POLST. Let me tell you what it is and let me tell you why. Because an advance directive is you stating your wishes. It's giving directions in advance about things that might happen in the future. And typically naming a decision maker. A POLST is a present tense physician's order. It's a PO physician's order. So it's a doctor's order now in real time that must ethically be honored. So if you say that's a powerful document, if somebody really is clear, I do not want to be resuscitated, it's time really to do a POLST, is at least the way I would recommend it, because that gives you the best chance of your wishes being honored in a crisis, which is why it's screaming green. Put it on the fridge. The ambulance comes rushing to the house. They're going to see that, they'll look for it, and they'll do what it says because it's a doctor's order. It governs your care.
They will still do all the comfort measures and they'll do all of the things that will keep you safe at home when the ambulance comes. But if it looked like you needed to be intubated or that you needed to get shocked or those kind of things, they would read the POLST. And if you had said you didn't want that, they would care for you, but they wouldn't do those things. They would bring you to the emergency department and they wouldn't do those things because that is a transportable document, carries with you from home to the emergency department, to the ICU, to the floor, to the rehab facility, to the nursing home. So it's not written in stone. It can change and evolve as your condition does or as your understanding of your condition does, but it's transportable and is a very powerful tool statewide. All the states have it now and they honor each other's form and they're very similar. The important part is to have the conversation. The next important part is to get your signature on that paper for you and your nurse practitioner or your PA or your doctor's signature. And it's even possible that if you are filling out a POLST on behalf of somebody, say somebody didn't have one and they recognized they needed it, but they were already in advanced dementia, or they couldn't make good decisions on their own, or there was some question about their competency. If they had an AD that was pre-existent, that was in line with, I don't want to have a lot of stuff done unto me, then you could help fill out a POLST for them. As a physician, I would look very carefully at the POLST. I would see that it's not the patient who signed it, but it is the identified health proxy, the decision maker that's been identified is signing on behalf. And if I would have that patient's advanced directives filled out years ago and see that it was in line with those, I would feel much more comfortable about not doing things. When we don't know, as physicians, when we don't know what to do, our default is always to promote life. And that's the challenge, because sometimes people have decided that they don't want all of that stuff done to them. But if I don't know what to do, I'm going to do it all.
We have time for one more question, and I saw Marcy's hand up, but I do want to let you know that if you have more questions, please put them in the chat window, and if you and we'll make sure that we answer them either today or that they're answered in a going deeper session soon. So please keep those questions and put them in the chat window for me, Marcy.
Yeah, I'm curious about if anybody, those of you who have experience in this, can talk about coma. It seems like that to me, if I was trying to help someone else make a decision, would be really tough, because sometimes people come out of a coma. That's one where I wouldn't know what to put in a directive. Can some of you lend a little bit of light to that?
Is someone available? It is a hard question. It's the hardest thing. I think that what happens is that you end up doing a therapeutic trial, and after a period of time, and is that 2 weeks, or is that a month, or is that 3 months? If there's a physiology that's understood about why this coma is present, and the docs can tell you the cause of the coma and the expected return from coma if it's possible, and if it hasn't happened by that date, it's reasonable to support for that period of time as a therapeutic trial, they call it. But if there's no recovery, or not sufficient recovery to meet your needs, what you would want or what the person would want, then I think then you make that hard call, which is how much longer on artificial nutrition, how much longer on a ventilator, how much longer as a bedbound person, because as a bedbound person, you lose muscle every day, you lose bone mass every day, you lose capacity of your lung every day. You become deconditioned every day. So even though you go in as a 45-year-old person in a coma, if you've been in a coma for X period of time, you feel when you come out of coma as an 85-year-old person. So there's so much decline when we are not meant to be laying in a bed on a ventilator, maintained artificially. So we lose a lot of ourselves and our bodies in that process. It's very, very difficult. I would say also, Marcy, that thing that's on all of the advanced directives where you're in an irreversible coma and you're never expected to come out of it, really that doesn't happen all that often. It's a really relatively rare. Very common is to be a reasonably healthy person, get a massive pneumonia, end up in the ICU intubated, you're on blood pressure medicine, you're on artificial feeding, you're on massive amounts of antibiotics, and now 2 weeks go by and you're not all that much better, you can't come off the machine, now you need a tracheostomy to stay on the machine. Now you need a surgical implantation of a feeding tube. Then you go from there to a place where you just live on a ventilator. So it's just complicated, and those are the things that personal conversation and the context and the physiology of the person involved becomes a process and and a trial. It becomes just purely a trial, I think, to be fair. And you can't say for sure at the beginning of anything how it's going to turn out. Only over time do you have more and more evidence, one way or the other. The ICU is a trial of life.
Shannon,
I'll answer, Shannon.
as I go back to screen share, Shannon, I wonder if I could read these two questions. Where do I get a POLST green card to fill out? And how often does the POLST have to be remade? Does it expire?
It never expires. You can remake it anytime. You can get a pulse from your doctor's office, probably. You can also order it from the end of life, the Washington End of Life site that we gave you the reference for in your handouts today. And from the Washington Medical Association that Amanda was talking about. So the pulse are everywhere. You could probably just go on Google it and order it to be sent to you for like 75 cents, I think it is. I want to talk about palliative care because it's relatively new, and I want you to know about it because it's marvelous. In spite of our human realities that we are all going to die, we want to believe that we can live until the moment that we aren't. And our hope in doing that is that we will not suffer and that we'll have the best life possible. About 15 or 20 years ago, a new specialty was created that was called palliative care, which is an approach. And it provides holistic support for quality of life for all of the domains of our life, physical, psychological, social, spiritual. It acknowledges that we are creatures of many domains. And you can get palliative care for any stage of serious illness. It used to be that palliative care was seen to be the same thing as hospice, that you would only do palliative care at the very end of life. But I would like to sort of nuance your understanding about that misunderstanding, because it's very common and many doctors have that same misunderstanding. Although palliative care may be rooted in hospice, it is very different because we focus on preventing and relieving suffering at any stage of life with a serious illness. And then the last little bullet point on that, it uses a multidisciplinary team. Why? Because we acknowledge that we are multifaceted humans and creatures. An ideal team on the next slide is composed, the goals are to eat and sleep, maintain function, and reduce stress. These goals of palliative care are different than the goals that you would hear from an oncologist, who might be, we want you to survive your chemotherapy, we want you to have your white cells back up again, we want you to be able to heal after your radiation therapy. Those goals are very different. We want you to get over your cancer. It would be different than the lung doctor who wants you to have less oxygen or to breathe better or to be able to walk further. Goals of palliative care is to add life to days and days to your life. So we're very simple. We really just want to improve your human experience of life and your human experience of dying if that's the situation that comes to pass, which for all of us, it will eventually. The team built around the patient as the center and the family is built of a doctor, a nurse, spiritual counselors, because every physical crisis is also at the same time a spiritual one. Don't you know it's true? So every time we become fearful, every time we feel vulnerable in our dis-ease or illness, something that comes up and surprises us, our spirit is also under attack. So we really use chaplains a lot. Nurses are trained in spiritual care. Social workers are trained in nursing. Doctors are trained in pharmacology. Pharmacologists are trained in how to care and listen carefully to people who are expressing spiritual distress. It's a marvelous team, a mature team can surround you and care for you just in serious illness. An example, lung cancer diagnosis, very scary, out of the blue, goes for surgery, has severe pain after the surgery, not well managed, calls palliative care team. Palliative care is often an expert group of people in managing pain. Not only the physical pain, but here's a woman who's otherwise healthy with a new diagnosis of bad cancer, and she has spiritual distress. Her husband, psychological distress. The palliative care joined around them and supported them through that rough time, asking different questions, listening carefully in a way that the cancer doctors don't do. They're doing their own thing. The internal medicine people don't do, they're doing their own thing. And what they're doing is valuable. So the palliative care team is an extra layer of support. And research now shows that it can extend the quality of your life, decrease the burden of any illness, and help you get through it to recovery, or help you get through it to the end more sweetly. It's possible. So don't forget about asking about a palliative care team consult when the time comes. If things feel like you could get more help from that's above and beyond your standard treatment team. Next slide. Palliative care is everywhere healthcare is because its goals are very simple. And so in this example of the circles, you can see that wherever acute care is, wherever chronic care is, ICU, neurologic problems, even in prison, there's palliative care. And you see hospice is a circle that's inside palliative care. Hospice is a kind of palliative care. It's not the same. Hospice, you'll hear more about next week, but it's a kind of palliative care which is limited by government law to be the last 6 months of your life, as based on two physicians' decisions about that, their best decision and best prognosis for you. So palliative care can go anywhere, and its purpose is to focus on you, the patient, your family, your community, and to help you do the things that bring meaning and value to your life. Next slide, please. Okay, so we're gonna flip through this same planning document page and focus a little bit more on the POLST. We covered a lot of it already. Again, I want to just reinforce that the POLST is absolutely necessary for anybody who's contemplating going on hospice, because by default, that means you have less than 6 months of expected life if the disease runs its natural course. Or you can fill out a POLST if you're ready, quote unquote ready. By that, remember I gave the example of the person who's been chronically ill back and forth for a couple of decades, who does not want to ever go into the ICU again, does not want to have heroic measures again. And so at the doorbell of her door is her POLST form tacked up by the front knocker. And so anybody who understands this person and who cares for her, or who comes through the door to visit, she's right up and open in her expressed wishes. Any ambulance that would ever be called to care for her sees that first thing. So she's very clear what she wants and doesn't want. The POLST form itself has 4 sections, sections A, B, C, and D. 2 of them of the sections are about emergencies, so about cardiopulmonary resuscitation. If they find you without a heart rate, without a pulse or breathing, so basically you're dead, do you want them to try to resuscitate you? That's the first section. The second section is about supporting your breathing and whether you would want to be on a machine. Then there's a non-emergency section, which covers things like feeding, artificial feeding with tubes, and then all of the signatures. And that's you as the patient, and your healthcare provider needs to be signed, to have that signed. The doctor or the healthcare person would say, would I be surprised if this person died in the next 1 to 2 years? And if a doctor would say, no, I wouldn't be surprised if this person died in 1 to 2 years, that is a particular patient that could benefit by going through the process of answering the questions that are incorporated on the POLST form. And I really do recommend that you go to the endoflifewashington.org for further information. I heard somebody say earlier that it was really helpful, and I really do acknowledge that that is really useful. I think next slide. We're going to do something fun before we go to our breakout section. And I'm going to show you some patterns of functional decline that we see at the end of life. And you're going to vote which one you would like to have. And to set up that decision, we're going to just kind of go through a couple of slides to start with. And before we got to be so super slick with our medical advances, it used to be that if you survived your 5th birthday back in the olden days, click again here, Kimmy, you would be very healthy until suddenly you weren't. So death was sudden and unexpected, and your death would come from an infection, something like you got stuck by a thorn, or you had a tooth infection, or an accident, a saber-toothed tiger, or you fell down off a cliff and really got bruised and bumped, and there's no fix for you, there's no rescue for you, and you would die. In the days before modern medical advances, life was much shorter than now. We really lived long. Even a life of 40 to 60 years old was pretty long-term back in the day. Next slide. Now, because we are very successful, we have loads of pills and medicines. We have ambulances that drive and fly and can carry you by boat. ICUs and emergency departments, life support technologies, so many advances that we can be rescued once we become ill and bring us back to better life than before we were ever sick. We do live longer for sure. Our life expectancy now is in the 80s, some places in the world up into the 90s. The question is, do we live longer and better? And I guess that's debatable because we have been able to add years to the tail end of our lives rather than adding years to the mid-range of our lives so far. And so that's a challenge for us because we do live longer, but we tend to live longer with one or more illnesses or some increase in loss of capacity. We have increasing challenges. We become more dependent on technologies, and life gets a little bit more complicated. And all of this is wonderful because we have life and we have love. But it's a mixed bag at times, and it becomes more and more challenging. Next slide. So this is what we see quite often in situations of cancer and organ failure. So hit the slide again, Kim. So here we see a profile of somebody who's basically healthy at first and has their first diagnosis, say, they have a lung cancer. And so they go for their surgery and they recover and they come back up and they do pretty well in that they get their chemotherapy, and then their health status goes down a little bit again and it comes back up, they finish their treatment, and then they do pretty well. And then, gosh, they get a pneumonia and they go back to the ICU, their lungs are vulnerable and they're intubated, or they get, really deathly ill, they come back up. So every time we can rescue, but every time it seems another crisis comes. And look at the overall trajectory of this baseline of health status. Over time, you see that every time you get better, it's a little bit less better than when you started. So welcome to being a human. This is how things go. And my question for you is, if this comes to pass for you or somebody in your family, where in this timeline is the right time to make an advance directive? Where in this timeline is the right place for you to complete a POLST? It gets to be a little bit tricky, right? So here's the next profile, the dwindles, what I call the dwindles. So here you are in pretty good shape for a very long time, and just incrementally you get weaker and less competent and less capable. And then maybe you're not making great decisions, maybe you have a fall, you just twist something, you have a sore back, you get weaker, you get pneumonia. You gradually get weaker and weaker and weaker, and you maybe don't have the same cognitive function as before. You need more and more support, and finally you come to a death. So where is the right time for you to make planning decisions in here? Where do you want to fill out your advance directive? Which of these squiggles? And what about the POLST? So of these profiles, I have to tell you that the one where you have really good life and then fall off a cliff, that's only going to happen for about 10% of us. So about 90% of us are going to have one of these others of the dementia, of the dwindles, or that repeated crisis at some stage. So knowing that this is the truth, and this is supported by research, looks like, your choice now is to decide which of these you would like. And then, and next slide, Kimmy. Thank you. So for the breakout, I'm going to ask you to choose which of these you would like to vote for, which of these you would like, and then what is the right time to plan? So if you break out into your group, please ask those questions and answer, and then maybe we'll be able to come back and share what your answers are. It's kind of a fun experience. We have always found it fun for you to vote. And so let's break now and go into our small groups.
All right.
Sorry, it shouldn't matter, Bu, because as long as that doctor is still practicing and that license number, which is on the form, is still accurate. I think what is important is that you have the conversation with the doctor with whom you are in relationship now. Because if there's any conflict or question, it would be just beneficial to all concerned to actually have had the chance to have the conversation.
Okay, thank you. Thank you. And we might want to update it.
Yeah.
I had a quick question about the POLST and for you, Shannon. Is it better to not call 911 if you don't want to end up in the hospital?
I think that that's a personal decision always. I think it depends who's there. What happens when 911 is called is they will come and they will honor those wishes as expressed, but they will also do those things which might be helpful, which might be help you get up or help the person get up. It can be to put that person on a gurney and get them to the emergency department, where social worker could be contacted, where whatever could be done to ameliorate the situation. So maybe just need fluids, for example. So you don't want to get resuscitated, you want to go in the ICU, but if you could get a bag of saline and you have a better blood pressure, maybe you have a chance to call the family, get yourself enrolled in hospice, and you have a chance kind of to put closure and pieces together a little bit better. So those kind of things can be helpful. So it's very context driven, but I think it's a great question. I usually just say call 911 because it's just an extra set of hands and heart and mind to help with the crisis. And then you unfold from there. There's just less pressure. Yeah.
One more question. I think Marcy raised her hand.
I just wanted to ask Shannon the question of who puts, I've only heard in one case of someone being on palliative care. Who puts that diverse team together?
The palliative care team exists. It's at UW. It's associated with all of the cancer centers. It's a marvelous specialty which is extant. And you ask your oncologist or your pulmonary person or whoever, do you have a palliative care team? Because I need emotional support, I need spiritual support. or I want to just be able to talk with my husband in a more supportive environment. It is unfolding and in relative stages of evolution and maturity at different agencies and facilities. But it is a powerful and well-recognized specialty which makes a difference in our lives as humans and patients.
Thank you.
Yeah, it should not be difficult. What I see most commonly is a doctor saying, oh, you don't need palliative care. We're going to give you 5 more rounds of chemo, or you don't need palliative care. We still have surgery to look forward to. That is not the correct approach. You can still get chemotherapy and do all of that. You can still go for surgery and all of that. Palliative care is an extra layer of support, which is still paid for like all of your other doctors and experts, and provides support in a way that supports your humanity and soulfulness in this event of fear and vulnerability for you and your family going through this process. It's an extra layer of support.
Thank you for that explanation. I have
Shoot.
lots of friends who work in palliative care, but I've never heard it so beautifully expressed. Thank you.
Should we have that written in somewhere on our advanced directives or someplace?
Sure.
You can.
No
You
question.
you can write anything you want to on your advanced directive view. Just like in mine, I specifically say Jeff has to put Vaseline on my lips every hour when I'm dying.
He shared that
And
with
eat
us last week.
So you can write it as detailed as possible. The advanced directive is the blueprint. You are the architect. You fill in the descriptions of everything that you want. Go
And I
for
would
it.
say it's the advanced directive, all of these are just communication tools.
Yeah.
And so you just use it to communicate what you would want to have communicated. If you want to add an extra paragraph that says, I define quality of life as blank, fill it in. You know, if you want to say a word to your family or doctors, just anything like that is helpful. You make it speak. It's your chance to speak for yourself on your behalf. So make it say what you want it to say.
Okay. Thank you.
I have a question to Shannon, maybe, and Jeff. And that is, it would be useful for me, even though I'm a physician, if I had some 10 case studies of people with common prevalent conditions in their 70s and 80s and 90s that would help me. It would stimulate my thinking, because I don't think very creatively when I think about all the different ways I could die.
One of the tools we gave you last week might do some of that, Dennis. It was 5 different scenarios, like in a paragraph.
Yeah.
Right. How about another 10?
Yeah, let's work on that together. Talk to everyone you see on the screen, and there's a lot of wisdom on the screen, right?
So we do have one more thing we want to make time for before we leave. I would really encourage you, as you come across questions and your thoughts and follow up from these sessions, that you write them down, send them to me or to our facilitators. I'll make sure they get into the right hands. And I just want to reemphasize that this is just kind of, we're driving at breakneck speed through all of these. It really is a survey course. So we're hoping after Christmas, if you all have the energy and openness toward it, that we could have longer sessions where we could spend more time in discussion and just spend more time asking the questions and discussing with each other. Next time we have a really, really full schedule, unbelievably full. Actually, we have Stephen Dougherty coming from Multi-Care Hospice to talk about hospice care. We have Karen Griffith coming from the community to talk about death with dignity. We have Tim Cook coming from Cook Funeral Home to talk about burials. And we also have a section on financial planning and wills. So we do hope you will join us for that. To close, it's just my great privilege to introduce Judy Friesen. I know Judy, and many of you know Judy through her work with the beautiful Threshold Choir in our community. And we're going to hear from her, and then we'll close our session in the most lovely way possible by listening to some of her harp music. So, Judy.
Thank you, Kim. What a rich evening. I'm sorry that I'm not part of the whole series because this is beautifully done, and I'm very pleased to have a mention of music because I think music can be really important. And I know it's late, and if you need to leave, I'll just jump to the end because my message is music can really facilitate a peaceful death. But let me go back to the beginning. So I'm a certified therapeutic musician. I play harp for people who are ill and dying. I play through the hospices. I played at the hospital. I played privately. And my work is to offer music in service of comfort and healing. So I need to say very clearly that I'm not a performer. What I do is not entertainment. It's to bring body, mind, and spirit. It brings the spirit back in, bring it back into balance. I'm not a music therapist. I don't try to rehabilitate anyone. I'm not a therapist. The music itself is the therapy. And I'm actually part of the medical team when I work on staff at the hospital. So this is nothing new, right? Cultures have always sung and played music to the ill and dying. So it's radical in that we're getting back to the roots. This is nothing new. And as Kimberly mentioned, I have a Threshold Choir. Right now, everything is suspended because of COVID, but there's nothing more honoring or sacred work that I can think of. And if you want to talk about death and dying, I'm right there because to me, it's so life enriching that it feeds my world. So sound is the first sense we get in the womb and the last one to leave when we die. I have played for people who are hard of hearing, who cannot hear my voice, people in a coma, people who are deaf. We hear the music through our bodies. Those sound waves are very, very real, and they resonate and they penetrate everything. I've had things on my windowsill shake if I hit the right resonant tone. And harp is the most resonant instrument there is. If I pluck one string, the other strings will vibrate. And those sound waves are really important. And we don't get that through a screen, and we don't get that through digital. I'm not knocking that. Keep playing music, but live music at bedside, when I can tweak it to the needs of the listener, is very different and very valuable. So I don't know what I'm going to play when I go see someone. I have a repertoire. I can improvise, I can play music. I love music from around the world. That's how I'm traveling right now, just by playing music. I can play familiar tunes, I can play minor tunes, I can do all kinds of things. But I walk in gently and quietly, and I notice, and I watch the breathing, and I look at the facial tension, and I look at the body movements, and I get clues, and then I try to meet the needs of that person. And that might mean all kinds of things. As we know, hospice can show up in every possible way. So if somebody is active and awake and alert, I might play something to distract them. If they're in pain, music can decrease the pain or take them away from that and have them drift to another world. If their blood pressure is really high, I can help bring it down. If it's really low, I can help bring it up. I can't know, the music comes through me. It's the music that does this. The music can regulate vital signs. I've played for neonatal with babies and seen the oxygen go right up there. A quick note, music can also be very cathartic. So if somebody's awake and they have something they want to play. I had a man who wanted to play loved Ghost Riders in the Sky. I think I'm the only harpist who plays Ghost Riders in the Sky. And he could only do the chorus. So he would sing the chorus and I would play it over and over and over again. Well, over the weeks I played for him, he got to where he couldn't sing anymore, but I know that still fed him. It still comforted him. Music can help people with life review. It can bring up those memories. I had another person who was young, he was in his 50s, and I played for him for weeks, very active. He loved the music. And one day he was pacing and he was agitated. And he got kind of angry at one point and he stopped and he looked at me and he said, the music, you didn't Music doesn't start with you. He said, there's a long white flowing cloth that comes from way back through you on into the future. And he started to weep. Well, I went and found a white flowing cloth, just a little World War II flying ace thing. And the next week I went back and I gave it to him. At this point, he was in bed and he couldn't talk anymore. But he held that cloth and he died a few days later. So sometimes it helps people connect. It comes in the back door. If someone is agitated or anxious, music can soothe. That deep sigh is the most common response I get. And it's not thought. You don't think I'm going to relax. It just comes in through the body and settles things. Can reduce stress. What do you think I've been doing these last couple of days? By the way, this is, I don't know if you can see it. This is the little harp I take with me when I go. I don't take my big harp. I kind of wear it. Music is like having a kitty on your lap. Those vibrations really do help. It can mask sounds. If there's a TV going on, I played for a woman last week. She kept the TV on because she couldn't manage the controls. You start playing music, you get the focus there, and you forget about that TV. It can ease you falling asleep. Sometimes I'll play and I'll fall asleep while I play, but don't tell anyone. If someone is on the threshold and they're actively dying, I don't play anything familiar unless they ask for it. I don't play with any kind of beat because like a drum beat is going to hold you to the present. We want people to let go. So I'll play without rhythm. I'll play without anything familiar. I'll play modal or minor music. Very slow, watch their breathing and help them slowly let go. It's happened so often where someone I'm playing for will die a few hours after I've left. Rarely while I'm there, but usually just right after. It certainly reaches everyone in the room. We can close our eyes, we can close our nose, you can't close your ears. So family, caregivers, everyone is touched by it. And I've often walked into a place where there's a lot of tension. You can almost feel the tension. People are anxious, they're upset. Music can even that out, calm people down, and often bring up the emotions. If you cry because something is beautiful, you're literally being touched by that. And I've seen a lot of things just calm. So I'll just say that music can start where medicine can't reach. It can come in where words can't touch. And it's something to offer when there's really nothing left to offer. Music is pretty magical, and I'm very honored to be able to play. So I'll stop there. The video that Kim is going to show you was actually filmed by John McKenzie. Hi, John. This was not meant for bedside. This is just a beautiful piece. So thank you all.
I forgot to unmute myself. You would not have been able to hear anything. So I'm going back, and just please feel free to depart after the video ends and go in peace. Go in peace, friends.
Thank you.